Hello, welcome and thank you for joining us today as we continue our IB Users Group webinar series. My name is Linda Herman and I'm the Client Relations Manager for Imaging Biometrics. Today's webinar is titled Gallium Maltolate, New Directions for Cancer Therapy, presented by Dr. Al Jazawi, Assistant Professor at the Medical College of Wisconsin. Dr. Al Jazawi will discuss gallium maltolate's promise in targeting various cancers, including brain tumors such as glioblastoma and pediatric high-grade gliomas. Before we begin, we're excited to share an update about our expanded access program for gallium maltolate. This program offers access for patients with recurring glioblastoma who may not meet eligibility criteria of clinical trials. In recent months, we have expanded the program's reach by activating several new clinical sites across the country. The EAP allows for gallium maltolate to be administered alone or in combination therapy. This option allows patients to prioritize quality of life as gallium has fewer reported side effects. The EAP reflects our dedication to advancing treatment options and offering hope to patients with limited alternatives. To support this effort, the Masella Foundation has generously contributed donations to help offset patient startup costs. For more details and information, please contact us at eap@imagingbiometrics.com. We have muted the microphones and ask that you use the Q&A feature to ask questions at the end of today's presentation. And with that, I would like to turn it over to Dr. Al Jazawi.
Thank you very much. I'm excited to talk about gallium maltolate with when they're not responding to treatment, or even if they're responding, usually within 6 months, they will recur. And we see that in our patient population on gallium maltolate, we're exceeding this progression, time to progression, just like we see on the animal side, which is encouraging, greatly encouraging, because what we see in culture, we can predict in terms of response on the animal side, and we can now hopefully use this also to predict on the patient side, because the trends are holding true, truly in a translational manner from culture to animal to patient. We see the same trends, we see the same responses between responders and non-responders, which is highly encouraging that we are on the right track. Now, I mentioned patient testimonials. Our animals are doing great. They are in much better body condition when we have to euthanize them versus the untreated animals. And we see this quality of life benefit in patients also. And this is something Dr. Conley likes to show. Patient that mentioned, I don't feel sick. I'm concerned that I don't feel sick. I don't feel like a cancer patient. My husband is concerned that I'm not experiencing symptoms and feeling sick. My husband is very concerned and worried about me, but I do not feel sick. So we definitely have a quality of life benefit in addition to this tumor inhibition. Now, just before I finish, I want to show, I'm really excited because we have some evidence that I would like to share that gallium maltolate may actually act as a radiosensitizer, which could completely open up our capabilities in treating patients that have really no treatment options, especially since radiation is part of virtually every treatment plan on the pediatric side, especially, but also on adults. Ionizing radiation works by essentially damaging DNA directly, but also by producing reactive oxygen species. Now, I've mentioned earlier, gallium maltolate increases reactive oxygen species production, which could potentially exacerbate the amount of insult that radiation can do to DNA, cancer cell DNA, but we also know that it inhibits DNA repair, which is probably the primary way by which gallium might benefit, give this boost to radiation therapy. Now, in culture, we're showing that compared to to radiation therapy and gallium maltolate therapy alone, combining the two, we almost have a 50% loss in viability in just conventional U87 cells. And even in the treatment-resistant glioblastoma cells we use, if we pre-treat with gallium maltolate, radiation therapy seems to have a much greater cytotoxic effect than if we just give gallium maltolate therapy alone. So we have here on campus a small animal radiation, a precision radiation machine, which allows for radiation planning, just like in the clinic. And we irradiated an animal with half the clinical dose. We gave 21, about half the clinical dose. Treatment protocols vary, obviously. It had an adult treatment-resistant glioblastoma implanted in its brain. We gave 3 doses of 7 gray each, so total of 21 gray. And we monitored with imaging. I gave some bevacizumab while the tumor was increasing to keep the radiation necrosis in check. And as you can see that after peaking around the same time, we have to euthanize our gallium maltolate rats because the tumors just grow so big. We saw a significant shrinkage in tumor growth in the gallium plus radiation treated rat. And this lesion increase, we've seen it before with monotherapy. It's really just cell swelling, cytotoxic cell swelling, just like what we see with radiation therapy. So that's why we see this lesion expansion happen. And this is not updated. This animal lived to day 245. But we see that combination therapy, radiation, and gallium maltolate quadrupled the survival essentially of our gallium monotherapy rats, and more than quadrupled essentially the survival of radiation only rats from a previous project. So obviously we're going to repeat this. Just very lastly, we have the capability now to monitor treatment effect with MR spectroscopy during our imaging, preclinical imaging. And we can longitudinally monitor treatment effect now. And we're showing that in our gallium maltolate treated and radiation treated rat, we see this disappearance of the choline to creatine peaks, which is our tumor marker over time. This is day 44 is our radiation therapy baseline after the rat was on gallium maltolate for a month. And we see this peak disappearing and the vinyl and lactate peaks just going up, which is necrosis. This has really continued up until like day 177. Vinyl peak, apoptosis peaks up, choline creatine ratio peaks just disappearing. So we have evidence of treatment effect. And this was then confirmed. Thank you very much to Melissa Pra, an engineer in our lab, who has presented previously on fractional tumor burden maps in this webinar series, where we are able to look at tumor necrosis and tumor and kind of this transition period. Imaging biomarker, and the fractional tumor burden maps really confirmed what we're seeing with the MR spectroscopy, that we see this just huge necrotic area building. And by day 105, you see there's really the majority of tumor is really just necrosis. There are a few spots where there might be some tumor. And once the rat was taken off gallium maltolate and left for another 6 weeks and monitored, it did develop neurological signs and had to be euthanized, which just shows that we didn't kill the entire tumor, and it's possible we used a only a half a centimeter collimator, and we might need a bigger one to get some of the external area treated too. But it seems to indicate that if we had continued gallium maltolate, this rat might have just kept going because we would have kept the tumor in check and stable. But this is something now this study we're going to repeat in some more animals this spring. And so we'll hopefully have some more answers. But what this indicates is that pretreatment with gallium maltolate followed by even just a half a dose of radiation therapy, seems to be highly effective in not just killing the majority of the tumor, at least in this animal, and maintaining this for quite a while.
Thank you very much, Dr. Al-Jazawi. Let's open it up for questions, and it looks like we have one here. It says, how does 240 plus days in a rat translate to humans with respect to overall survival?
Years. I don't have the exact number, but it's years. There is a formula, there are some papers out, but usually a week will translate to months. And then we're looking here at months already, so we're looking at years, translating that to patients. Potentially, right? Potentially.
Thank you. And then from Dr. Mazzella, have you tried GaM during radiation in GBM patients?
No, that is planned for our phase 2 clinical trial. This is, like I said, this is hot off the press. This is really, I just finished this January 1st, this project, the data for this rat.
Okay, another question. Would the expanded access program allow use during radiation?
It should, I think. That might be a question for Dr. Shitamba or Dr. Conley, but I think it should allow for that.
Okay, and a comment here. A quick online search says 13.7 rat days equals 1 human year, thus 240 rat days equals 17.5 human years. That's quite a long time.
Yeah, I wouldn't probably go that far, but yeah, I mean, years. And I think for a patient with glioblastoma that has only, a survival outlook for a couple of years, like glioblastoma is a terminal cancer, regardless what we throw at it. To add even just, another 3 or 5 years with great quality of life, I mean, that's already a bonus. And on the pediatric side, what I didn't mention, those pediatric patients with ATRT, those are like, 2-year-old kids that don't have a long life expectancy, a couple years maybe. They rarely make it past 5. Highly burdensome, highly toxic treatments, really poor quality of life. And so just adding some more years with a better quality of life, again, that's a win in my book. So I wouldn't focus too much on the numbers or like how much. I think what we need to focus in is that I think the quality of life component is, I think for most cancer patients, that sometimes outweighs for how long they're going to survive. But if we can, on top of that, add years, maybe not 17 years, I'm not sure that's a long-term study. We're not set up for that. But if we can add several years to that, then I think, yeah, we're halfway there, right? We can't cure it maybe, but we can keep it at bay.
Yes, okay. Dr. Sengupta has a few questions, so I'm going to start with the first one. Have formal quality of life metrics been tested, and is there an intent to do this in the phase 2 trial?
So not in the animals. In the animals, I use body condition, body weight, which is typically on an increasing trend over time. They don't lose body weight. Towards the end, they're also cognitively, the rats are in much better shape, activity-wise, body condition-wise. We haven't done any behavioral studies yet. That's something I would really like to explore, to look at any differences in, or changes in cognitive behavior activity. And then on the patient side, I don't know, I'm not sure how much other than beyond like a KPS score would be incorporated on the phase 2 trial. But I know there are some basic metrics in place, but I don't think it's a big component in terms of like special research component at this time.
Okay. And in terms of stable tumors, can you elaborate what tumor types is this regardless of molecular profile?
So the best we've seen right now was in ATRT. Granted, we tested the cell line that was most sensitive in culture, but we've seen this kind of trend even in the glioblastomas, both adult and pediatric, where we just see this kind of plateauing of the tumor volume where it doesn't change for a few weeks. And then it tends to take off. And we don't know what happens at that point where it just changes in growth, where it just sits there and then suddenly decides to change. We don't know yet what's happening there. Hopefully that's something we can explore with some upcoming grants. Because once we figure out what makes the tumor take off after responding for quite a while, I think then we have options. It gives us an opening to then use either secondary treatments, change our dose, maybe we'll have to give it twice a day instead of once a day, stuff like that. And so we need to first understand what's happening, what really keeps it in check. It's possible that we're inducing some kind of senescence and just make some of the cells dormant rather than killing them. But at this point, we don't exactly know really what keeps it stable. That's definitely a big knowledge gap.
Okay, and a third part of her question, iron in cancer cells can be dictated by nutritional intake. Any thoughts of looking at diet as a data point?
We just in our just the grant we submitted this January, actually one of the aims in the animal portion of the protocol is to look at low and high iron diets compared to standard iron diet and see how that affects sensitivity to gallium therapy. So we've proposed it, we haven't tried it yet. Cell culture indicates that if you have higher iron environment in the tumor cells, then usually gallium is kind of outmaneuvered a little bit, and the cells are they're less sensitive because there's more iron to kind of counteract that. But we don't know in vivo, we don't know yet. But we have proposed it and we're planning to look at it.
Okay, very good. And she comments there might be a way at looking at system XC.
I'm sorry, I didn't catch that last portion.
Let me see if I can allow her. Okay, Dr. Sengupta, do you want to go ahead and ask Dr. Al-Jazawi yourself?
Yeah, my suggestion is rather than just looking at iron, you might want to look at system XC, which is the transporter that moves cysteine and glutamate, because that basically is contingent on iron. And you can have diets that are linked to iron metabolism and ferroptosis, which might enhance the activity of gallium maltolate.
Oh, interesting.
And yeah, the person I would recommend that you collaborate for that is actually here at UNC. Okay. He's going to be having a nutrition study that opens up, looking at the System XC transporter. So you might be able to collaborate with him on that.
All right, that sounds great.
Thank you, Dr. Sengupta.
You're welcome.
It looks like that is the end of our questions. So I think this concludes the meeting for today. This will be recorded and made available. If anybody has questions for Dr. Al-Jazawi or would like to help me facilitate connecting anyone, please just go ahead and email me at eap@imagingbiometrics.com. And again, thank you very much, Dr. Al-Jazawi, and thank you everybody for joining us. And please look forward to future webinar invites. Have a great day.
Well, thanks for having me.